Hello everyone and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber. Welcome back everyone. Today we'll have a look at a paper exploring the potential benefit of bariatric surgery in terms of breast cancer risk, recently published on JAMAsurg. Following that, we will have a quick chat about multi-arm randomized controlled trial and particularly adaptive design and a few examples about that. I'll leave you to it.
So my name's Sam. I'm one of the core surgical trainees currently working at St James's. The paper that we've chosen today, the title is Breast Cancer Risks After Bariatric Surgery and Influence of Insulin Levels, a non-randomized control trial, which was written by Christensen et al. And published recently in the JAMAsurg journal of May this year. I've done this presentation with Constantine.
So looking at the background of this study, breast cancer is a common knowledge that breast cancer is one of the most common cancers among women and is the leading cause of cancer-related death as well. Obesity, we know, is one of the identified risk factors for breast cancer and several other cancers. The mechanism for which this happens is not well known, but insulin resistance and hyperinsulinemia have been suggested as the mediators for the increased risk of cancer in people with obesity. We know that bariatric surgery is the most efficient way of controlling large and sustained weight loss in individuals with obesity. Some retrospective studies have suggested that there is a relationship between bariatric surgery and reduced breast cancer risk in women, but these have not been confirmed with any long-term prospective study. And this is where this particular study comes in. I will point out that this is a secondary analysis of an original work, the Swedish obesity study, which was designed to investigate the long-term effect of bariatric surgery on obesity-related morbidity and mortality. I'll pass on to Sam for the PICO.
Yeah, so in terms of the population selected for this secondary review, they used females aged 37 to 60 years with a BMI of greater than or equal to 38. In terms of the intervention, that was bariatric surgery, which included gastric banding, vertical band gastroplasty, and gastric bypass. And the comparison, so the control group was usual obesity care, but the report doesn't expand on what that exactly entails. And then the outcome measured was breast cancer, which they used the Swedish Cancer Registry to look at patients that had breast cancer. And they used insulin resistance as per the HOMA-IR formula.
Thank you, Sam. So this secondary report was aimed to evaluate the association between bariatric surgery and incidence of breast cancer in women with obesity, and to check if this treatment benefits from bariatric surgery is modified by the baseline insulin levels in these women. I would point out that these aims were not predefined in the SOS study from where the data for this analysis was taken. I'll pass on to Sam for the method.
Yeah, so the original Swedish obesity study, which is where this report got its data from, so that original study was a prospective matched non-randomized trial, and they recruited participants through campaigns, mass media, and they used 25 public surgical departments and 480 primary healthcare centres in Sweden. So the inclusion criteria for this original study was patients aged 37 to 60 years with a BMI of greater than or equal to 34 for males or 38 in females. Of these patients within the study, there were 2,010 which had bariatric surgery and 2,023 in the control group. They then used matching for 18 variables on a group level. And this study ran from September 1987 through to January 2001.
In this particular report, they looked at the data that relates to the women in the SOS study. The bariatric surgery group comprised of 1,420 participants, and the matched control group 1,447. What was done for these participants were the same at all levels. 4 weeks before the surgery, both the intervention group and the control group had examination. The details of the examination not documented in the study. And after the intervention, at 6 months, there was repeat examination, and this was done yearly for 3 years, 2 yearly for 6 years, and then repeated at 15 and 20 years. At each of 2010 and 210, 15 and 20 years, blood tests were taken for biochemical analysis, and the median follow-up for this patient was 23.9 years. The interquartile range was 20 to 27 years. I'll pass on to Sam for looking at this diagram, just to mention that the lower bits of it were what was included in this particular report. Out of the 2,867 women in the SOS study, 1,420 was in the intervention group. 5 of them were not included in the final analysis, 4 because of missing data, and 1 had cancer incidents before the inclusion. The final analysis was done per protocol. I'll pass on to Sam for the outcomes.
Yeah, so as we've mentioned before, the outcomes of the original study weren't predefined, and this review has looked specifically for breast cancer, which they used the Swedish Cancer Registry. So they found that 66 breast cancer events occurred in the bariatric surgical group and 88 occurred in the usual care group. This was an incidence rate of 2 per 1,000 in the bariatric surgical group and 2.9 per 1,000 in the usual care group. So the unadjusted analysis showed that bariatric surgery was associated with a reduced risk of breast cancer, but after adjustment for variables such as age, BMI, alcohol, and smoking, it was found that the reduced risk wasn't significant, statistically significant. And then we've just got a table here that lists all 17 baseline characteristics, and 12 of these were found to be statistically significant between the surgical group and the usual care group. And then we've just highlighted 4 here that we think are some of the most relevant variables and characteristics with regards to this study, such as age, BMI, smoking, and HOMA-IR. And then just a graph here that essentially shows it shows the follow-up time and the incidence of breast cancer between the 2 groups. So for the first sort of 10 years, there doesn't seem to be much difference. And then from 15, 20, 25, and 30, the usual care group start showing an increased cumulative incidence of breast cancer compared to the surgical group.
So they did subgroup analysis and stratified the women based on the baseline insulin prior to bariatric surgery. And they had two groups, one group with insulin levels below the median of 15.8, and the second group, insulin levels above the median insulin level of 15.8. For this subgroup, there is no difference between the intervention and the control group. The incidence rates of breast cancer in both groups were 2.2 per thousand. But for those with insulin level above the median insulin level, there is a statistical significant difference between the two groups in terms of the incidence of breast cancer. In the intervention group, 2 per thousand had breast cancer. In the control group, it was 4 per thousand, and these figures were statistically significant even after adjustment for age, BMI, alcohol, and smoking risk. They also, the graph here illustrates what I've said. The graph on the right show no difference, and these were for the women with insulin level below the median value. On the left side of the screen, we could see that from 10 years, there's significant difference between the usual care group and those that had bariatric surgery. I would hand over to Sam.
So limitations of this study. So the self-reported limitations were firstly, the original study that they used data from was non-randomized. And it was stated that this was because bariatric surgery had a high incidence of mortality and it was unethical to randomize this trial. Secondly, there was statistically significant difference in 12 of the 17 baseline variables that we've already touched on. They said that the study included older surgical methods that are no longer used. So some of the bariatric surgical interventions aren't done today. So the results from this study are going to be of limited value because of that. There was no information available on estrogen levels or breast cancer subtype, which again would be useful in a study that's looking specifically at breast cancer. And breast cancer incidence was not a predefined outcome, and the analysis of this report should therefore be regarded as exploratory.
Some of the other limitations we've identified here is it is difficult to say that this is a prospective study. The data was collected prospectively, but the aim was not predefined. The outcome was not predefined at the time of data collection. And these were done prospectively. So I'm not certain if this is really a prospective study. Someone in the group can give a voice to this. Again, the SOS study has published lots of papers about obesity, bariatric surgery, and cancer risk. And in the previous study, they've shown that high insulin levels and bariatric surgery have association. And what they've demonstrated is women with high baseline insulin level and who had bariatric surgery had reduced risk of female-related cancers. So one wonders what new information this particular article is providing. Again, there was no mention of family history of breast cancer if they checked for this or they didn't. And this is a big factor when we talk about cancer incidence and risk. They had a large sample size to go with, but there was no calculation to determine what level of sample size or participant that will be needed to power this kind of study. So these are some of the other limitations we thought there are in this study. I'll pass on to Sam for conclusion.
Yeah, so the conclusion of this study essentially was that there was a reduced risk of breast cancer after bariatric surgery in women with obesity. The surgical treatment benefit was predominantly seen in women with hyperinsulinemia, suggesting insulin may be used as a predictor of treatment effect. And then in the table below, we've just written some positive and negative points with regards to the methodology and the clinical aspects of the paper. Thank you.
As usual, a brief summary about what we discussed after the paper presentation. The focus of the discussion revolved around the study design. Really, we felt after the presentation that rather than a non-randomized controlled trial, this was a retrospective cohort study. A couple of points made us reach this conclusion. First of all, the outcome presented in the paper was not pre-planned in the analysis, and certain information were missing as a result, which is an issue that often is encountered when analyzing data in a retrospective cohort study. We also had a chat about the role of high preparative insulin and resistance and normal preparative insulin resistance versus the risk of breast cancer, and the difficulty in considering a pre-intervention variable as a potential indicator of postoperative benefit. That is to say, patients with high insulin resistance seem to benefit the most from bariatric surgery in terms of reduction of breast cancer risk. However, it would have been much more useful to determine whether such insulin levels and insulin resistance was actually decreased after surgery, and whether that correlated with the risk of breast cancer. Furthermore, a number of malignancies are associated with high insulin levels, and we couldn't fully work out why that specific type of malignancy was chosen by the authors. We finally had a brief chat about the matching methodology utilized in the original SOS study and how this type of matching could introduce confounding variables and selection biases. We'll ask questions to the authors, and as usual, we'll let you know. Congrats.
Right, so today I'm going to give you a brief overview on adaptive trials as sort of a last little talk on multiple answer RCTs. Let's start with the definition as usual. We're talking about adaptive design. Adaptive design is basically a method that allows modification to the trial and or statistical procedures of the trial itself after its initiation without undermining validity and integrity. A mouthful, I would say, and we're certainly going to have a look at some examples on how this applies in real life. But it is becoming more and more valuable and more used in trials that we're coming across, particularly after COVID. So I think it's worth having a look at it. Now, let's go back to our last session for a minute. As you remember, we talked about master protocols, and I did mention something about adaptive design, particularly as applied to one of the three master protocols that we commonly encounter, particularly the platform trials. So if you recall, platform trials are trials that basically investigate multiple targeted therapy in a perpetual manner, normally in the context of, for example, a cancer or a disease, where there are also often a variety of subgroups due to molecular characteristics of the cancer, etc., etc. And when adaptive design is implemented in the context of a platform trial, we talk about APTs, or adaptive platform trials, which is where we most commonly encounter this type of methods, this type of designs. But APTs is not necessarily equivalent to adaptive design. And when we talk about adaptive design, actually all we mean is, as you can see in this relatively simple diagram, that we are designing a trial and we are embedding a series of review methods within the trial that runs in parallel with the conduct of the trial itself that allow for adaptation on the design. Once the trial is then conducted fully, or at least some of the arms that are in the trial reach a conclusion, the data gets analyzed. This is in contrast with the traditional fixed sample design, where you start with a specific design, you conduct your trial, and then you do your analysis. You might have some interim analysis that are planned in it, but they're not as nuanced, not as detailed, not able to modify the trial itself as it's running, but rather just stop it or allowing it to continue, if that makes sense. So if you think about it in a sort of set of groups, within the group of randomized controlled trial, you got master protocols trials, adaptive trials, and in the middle of it, you've got adaptive platform trials. And for most of the rest of the lecture, we'll be talking about APTs, or adaptive platform trials, and some of the bits and bobs that go with it. So we said that adaptive trials allow you to make modifications to the trial itself. Those modifications can affect a number of things. Today, we're going to focus on two, particularly patient selection and subgroups, and we're going to briefly touch on enrichment and patient randomization, and we're going to talk about adaptive randomizations in the context of particularly one breast surgery trial. And there are many other examples out there, but these are the two that are most commonly used. And in order to understand how these two modifications, these two types of adaptations are implemented, we need to kind of have a look at what an intermediate outcome measure is, as this is kind of necessary for the trial to be adaptive. So when we talk about an intermediate outcome measure, we're talking about an outcome that allows for screening for emerging evidence of activity of a particular intervention. We'll talk about some examples that will make it a bit clearer. But basically, an intermediate outcome measure happens early and frequently compared to the outcome measure that you're actually looking at for the overall trial. And it is supposed to be on the causal pathway to the outcome measure that you're looking at in your trial at the end. I think an example will make it a bit clearer, and we're going to talk about prostate cancer, and particularly we're going to talk about a trial that we touched upon before, the STAMPEDE trial. So STAMPEDE trial is one of the longest sort of lasting platform multi-arm trials, and you can see a graphical depiction of it here. Started in 2006 and is still ongoing. The primary outcome of the STAMPEDE trial is overall survival, and it is about metastatic prostate cancer. Now, as you can imagine, it will take a long time to get data about overall survival when you start recruiting patients in a trial like this. Years and years and years and years and years. And sometimes this is practical, but certainly if you are trialing 5, 6, 7, 8, 10 interventions, and you want to fairly rapidly identify interventions that are promising or not promising, it becomes very unpractical. And we did talk about different types of survivors before, so we kind of have to imagine how the investigators felt when they thought, well, how are we going to do this? We can't really wait 20 years before we start dropping arms out of a trial that involves 7 or 8 interventions. So if overall survival will take a rather long time, we need to choose something that's more common and happens early. So the authors decided to go for failure-free survival, or rather ironically, the acronym FFS. Failure-free survival is a rather broad definition, and basically means you've got prostate cancer, you've got some treatment, and we do want to keep the cancer under control. when the cancer is not under control and is progressing, then it means that your treatment has failed. And that's when you got failure-free survival. This will happen much sooner than death. So it will allow you to kind of get a gist of whether your treatment is working or not much sooner. But it's still very hard to actually obtain a universal definition of failure-free survival. It is very difficult to measure in a timely manner when you are following patients up. So the authors decided to choose something that is causally linked and very easy to measure. And in this case, PSA is the simplest possible one. If you have prostate cancer that is metastatic and you are being followed up for a number of years and your PSA starts rising despite you being on treatment, well, it's probably because your treatment is starting to fail. It is an assumption, but it is possible. And I have simplified quite a lot of things here. But basically, this is the reasoning behind it. So you need something that will allow you to capture very early if what you're doing is going to work or not. And this is your, in this case, PSA. If you go on the website of the Stampede trial, you'll actually find a calculation tool that is available to classify your patient if they're having biochemical failure or not. It's called the PSA progression value calculator, and you can go online and have a look at it. So PSA, and generally speaking, treatment failure is a good example of an intermediate outcome, something that allows you to make assumptions about how treatment is going to go in the longer run and how overall survival is going to be. Obviously, it does have some pros because, again, you can assess things pretty quickly and rapidly during your trial, and it allows for adaptive changes to your trial. So it's PSA in patients that are treated this way is skyrocketing very quickly. Obviously, this is not working. Let's drop it. Something along those lines. But it does have quite a lot of cons as well, especially, I feel, in the case of the Stampede trial, because it is based on assumptions. You are assuming that a raise in PSA relates to overall survival. But if you're dealing with a pathology that is actually very, very slow progressing and that would not necessarily cause the death of the patient regardless, simply assuming that treatment failure will correlate to overall survival is not necessarily true. You can't necessarily make that assumption or assume that that assumption is actually reliable. And we did talk about it when we looked at diagnostic tests and particularly screening. Often, you rely on a particular type of test to detect a pathology very early, or detect that a pathology is progressing, like in this case. But that doesn't necessarily mean that you are going to detect patients that are going to die sooner, because that pathology might not catch up with them. It might be something else. So you're assuming in this case that PSA will relate to overall survival. And because you are making that assumption, you risk dropping arms prematurely, arms that might actually be beneficial to the patient for other reasons. So now that we've talked about the intermediate outcome measures, we can have a look at a couple of examples of how they help adapting trials. And particularly, we're going to talk about enrichment first. Enrichment is a technique that uses interim data to identify treatment that are particularly effective in some patient subgroups. To give an example, we're going to talk about breast cancer, and particularly another one of the oldest platform adaptive trials out there, the I-SPY2. In the I-SPY2 trial, patients with breast cancer are recruited and are given neoadjuvant treatment. So they're given various forms of different treatments before having surgery. And then they are followed up and operated on. And the primary outcome of the study is pathological complete response. And that is because we know that if patients have breast cancer, have treatment, and then they have a pathological complete response, when they're operated on, they get better outcomes. And that's the sort of overarching theme of the I-SPY2 trial. But the I-SPY2 trial subdivides patients into 10 different subtypes of breast cancer. And different treatments are tested in combinations with each biomarker and treatment. So some treatments are available only for certain subtypes of cancers. Some treatments are trialed on all subtypes of cancers, and then they are dropped or continued depending on how effective they are. To cut a long story short, when a treatment is tested in a phase 2 manner, so in the sort of initial stages of testing for treatment, those treatments can either graduate or fail across the length of the study. A treatment graduates when it is estimated to have an 85+% chance of being effective at inducing a significant difference in pathological complete response. It's dropped or fails when the chance of it causing a significant difference in pathological complete response is 10% or less. And this is decided very, very early in the course of the study. And you can see here on the left how in the I-SPY2 trial, they've already tried a massive number of different types of treatments. And based on a very quick, very early analysis, the authors were able to graduate some treatments to the next stage where we're talking about phase 3 trials and fail some of the treatments that were absolutely not promising. And these can apply to different subgroup of patients based on the original biochemical analysis. The intermediate outcome measure that they used to do this is actually serial MRIs. So as they were designing this study, they realized that preoperative MRIs were actually correlating pretty well with pathological complete response. So they do MRIs at time 0, 1, 2, and sometimes 3 and 4. And based on the data they get across the neoadjuvant treatment, even before knowing what the primary endpoint is going to be, they are allowed to drop or graduate treatment to the next step, if that makes sense. Now let's talk about response adaptive randomization. Now response adaptive randomization is kind of an evolution of what I just described to an extent. And it's a technique that allows researchers to change the frequency by which patients are randomized to one treatment or the other based on success likelihood. This is a technique that requires a lot of pre-trial simulation and planning in order to maintain sort of the overall reliability of the experiments that you're doing, in order not to jeopardize your results. To give you sort of a diagram of how this works, when the trial starts, you'll have a number of different treatments available to you and a control arm. In this case, we've got 3 different types of treatment. As the data start trickling in and patients get randomized, it becomes evident, based normally on interpretation of an intermediate outcome measure, that some treatments work better than others. And an algorithm that's been designed before the trial started starts changing the way patients are randomized, putting more patients in groups that are more promising, such as treatment number 2, and less patients in treatment that are less promising, or number 1. As the study progresses, some treatment might show themselves to be so inferior that the algorithm will just stop randomizing patients to that particular treatment and drop the arm completely. If, as the treatments go along in the study, they show themselves to have been so superior, then a treatment might just get promoted to the next stage or just deemed effective enough that it doesn't need any more patients recruiting in it. Again, they did this in the I-SPY2 trial. So using interim MRI data, patients across the I-SPY2 trial can get randomized in bigger numbers to a particular arm and in lesser numbers to a different arm. And as you can see here on the left, you can see how different the numbers are for arms that started pretty much at the same time, and how quickly certain arms failed or graduated, for example. Now, obviously, I've talked about chemotherapy drugs for prostate cancer and chemotherapy drugs for breast cancers, but what about surgical interventions? Are there any examples of adaptive design as applied to surgical interventions? Actually, I've not found much, despite what I would describe as a reasonably extensive research. I found a trial from orthopedics that's called START Reacts that has to do with non-repairable rotator cuff tears, and particularly the use of a balloon spacer. Now, I know Sam is an ortho wannabe, so he might correct some of the orthopedic inaccuracies that I'm going to comment on in the next minute or so. But basically, you have two types of rotator cuff tears that can be repaired and tears that cannot be repaired. In tears that cannot be repaired, it is postulated that using a balloon spacer, which is a technology that has actually been around for a number of years, will make outcomes better. And it has been debated across the orthopedic community, as far as I understand, for quite a while, whether that's true or not. So a group of researchers designed this particular study where for non-repairable rotator cuff tears, they will put in one of these balloon spacers versus not putting in a balloon spacer. And the primary outcome will be an outcome questionnaire called the OSS at 12 months. They embedded what they describe as adaptive technology or adaptive design based on simulation models, whereby if the OSSs at 3 and 6 months are convincing enough that the treatment is working, or convincing enough that the treatment is actually not working, the study can actually be stopped. And there's quite a few editorials out there in orthopedics journals describing these as innovative and adaptive. To me, it looks just like an interim analysis as it was planned in the old days, but I appreciate they've done some simulation models to corroborate that, but I don't think is that revolutionary, if I might say. A further example of multi-arm trial that does use adaptive design to a certain extent is Rossini. I'm sure general surgical trainees have been subjected to recruiting for Rossini, which has been ongoing for a number of years. It's a trial that has to do with infection control and measures that are taken in the operating room to reduce the SSI risk. It started with a number of potential candidates, treatments that were deemed to potentially be ineffective. And as time went along, we actually realized that none of them worked. And based on very accurately planned interim analysis, a lot of those arms were dropped between stage 2 and stage 3. And we are now in stage 4, where basically the researchers are thinking about implementing new, putting into the trial new arms to test different technologies against controls that have already been recruited or are currently being recruited for Rossini. And to an extent, this is certainly a multi-arm, multi-stage trial, which does use adaptive design, particularly in terms of including and dropping arms that are not effective. So to sum up what I've just discussed, we talked about what adaptive design is in broad terms. We talk about an essential concept that allows you to implement adaptive design, which is the intermediate outcome measure. We briefly touched on enrichment, and we briefly touched on adaptive randomization. And finally, we talked about very limited surgical applications that are out there in the literature.
Thank you everyone for tuning in and listening. Until next time, keep ramming your life with our surgical podcast.